a lot. Hit the button. There we go. All right, and oops. And so the objectives of this talk is basically just discuss some of the new drugs for actionable mutations, as well as one or more new drugs for small cell lung cancer, and discuss how we develop new targets in non-small cell lung cancer with a few examples, as well as evaluation of new delivery systems. So I'm going to talk about these new drugs for targeted mutations right up front. So one area that's going to be important is this area that we call the problem of resistance in oncology, what I would call PRO, not patient-reported outcomes, but the problem resistance in oncology. And this comes with the fact that cancer cells continue to change and mutate. They find ways to actually escape our treatments. And so the idea is that what was originally a tumor that you're treating with particularly a targeted drug, eventually the sensitive clones die off, leaving only the resistant clones. And those resistant clones now are free to actually grow unfettered by the bulk of the sensitive tumor cells. And over time, the resistant tumor kind of takes over. So now the drug no longer works. And you have to find some way to deal with that. So this has been happening for a while. We started off initially with crizotinib as a first-generation drug, and then eventually with ceritinib, and then alectinib, and then brigatinib, and now lorlatinib. So all of these IB drugs are second or third generation. So alectinib and brigatinib are considered second generation ALK inhibitors, and lorlatinib is considered a third generation. But there are new drugs that are what we consider fourth generation drugs. There's TPX0131 and Nuvalin 655. I'll talk briefly about both of them. So Nuvalin 655 has a particular sensitivity. I know this looks like a bunch of tree branches or a fern, but if you actually look to actually see that blue little circle that you see is actually where that drug is located along this phylogenetic pharmacological tree. So in other words, the more that it is likely to work on one target, like ALK versus ROS, the more it veers towards that direction, for instance. So in this case, this drug is fairly selective for ALK, but also has some selectivity for ROS1 as well too, and much less for other types of targets. What is important is that compared to TPX0131, which is the other drug that's in development right now, Nuvalin 655 is primarily focused on ALK and has very little TRK side effects or targeting TRK, whereas TPX0131 also can target NTRK. That's good and bad. It's always to have a drug that can target more than one thing. But the problem is the fact that you get all the side effects associated with it. And anyone who's using a drug targeting NTRK realizes that's a whole bunch of new side effects associated with it, with lightheadedness, dizziness, muscle weakness, difficulty with taste, changes in one's taste, which is very bothersome, things like that. And so you don't see that with Nuvalin 655, but it is more selective for ALK. So you're limited to kind of focusing on these patients as outpatients to target. This is a busy slide. It basically summarizes to Nuvalin works at very low concentration. So the Nuvalin 655 works at low concentrations to target many of the resistance mutations. This is preclinical data. I can't say anything specific except to say that based on where we are right now with the testing, which is between 50 and 200 milligrams, this drug apparently is able to reach the same concentrations that the cell lines can reach in order to actually control multiple mutations associated with ALK fusion. So in other words, many of the resistance mechanisms are related to these new mutations that develop. And the bottom line is that at the concentrations at 50 milligrams and above, it all works. We have one patient on 25 milligrams and the tumor shrink after 2 cycles, 33% already. So in other words, this is a very potent drug. It also works very well in the brain. In here, you see experiments where they have tumors in the mice. Those are the little purple things that you see in the brains. And then after treatment, you see they're all gone. And not only that, the mice live longer as well, which also proves that this is an effective drug in this way. And compared to lolotinib, which is the otherwise most effective drug to get into the brain right now, Nuvalin is very comparable in the sense of getting into the brain. So this is a good drug. We're in phase 1 development. We have about 3 or 4 patients on right now. And so these days, particularly since in Ontario, we're only allowed one ALK tyrosine kinase inhibitor, and after that, there's no more funding. That if you do have patients that are in that field, definitely send them to us. The trial is open here, and the spots are starting to open up as we finish the phase 1 portion and move on to the phase 2 portion of the trial. Now, on top of that, the other partner to ALK is that there's been a lot of research on ROS1. So ROS1 is another fusion. It occurs in less than 0.5% of non-small cell lung cancer patients. ALK is more like 2 to 5%. And the bottom line is that there are a number of drugs that are used before for ROS1. 2 of them are now funded in Ontario: crizotinib and entrectinib, which are listed here. Crizotinib works quite well for ROS1. Only problem is that it doesn't get into the brain quite as well. So if you have brain mets, or if you're trying to prevent brain mets in these patients, it may be difficult. And so we've been moving towards entrectinib. The problem with entrectinib is this: it has a lot of TRK-B side effects because the drug is used not only for ROS1, but also for NTRK. Hence the really cute name, Roslitrek, right? For ROS1 and NTRK as well. The problem with entrectinib is the fact that it has a lot of TRK-B side effects. Those side effects that we talked about, the change in the taste in the mouth, issues with just severe fatigue, muscle aches and pains, weight gain. There's a whole series of things that are quite bothersome in here. So I've generally found that it's sometimes difficult to get up to the full dose of 600 milligrams. And for many patients, if you start with a high dose, they kind of get upset. So I was talking with Barb Milosky in BC as well. We start at the 1 pill a day because you're supposed to take 3 pills a day. 1 pill a day for a few weeks, and then up to 2 pills, and then up to 3 pills to build this up. So that if you run into problems at the lower dose, you kind of keep them there for a while until things settle and you can decide whether to increase or not. Many of us are finding it difficult to just slam in the 600 milligrams and 3 pills immediately. But then, even then, our problem is what happens when they fail. There is a drug, lolotinib, which is used for ALK and ROS1, that we can apply to Pfizer for. And they will give it to us right now, but we need better drugs. So that's why we've actually opened all trials for all 3 drugs. Repotrectinib, TPX0005, which was a Turning Point Therapeutics drug, but the company has just been bought by Bristol Myers Squibb. So it's going to be developed further for sure. Taletrectinib from Anhart Therapeutics, which is in phase 2, and Nuvalin 520 in phase 1. So the one in blue, we finished accruing the Trident-1 study for repotrectinib. The other 2 we have open right now at our center. So we're excited about that. So what about the data for all 3 of them? Well, repotrectinib or Trident-1, if you look at the swimmer's plot on the left, right, there are patients that are on many, many months, past 2 years in some cases. There's one patient that went all the way to like 3+ years. So in effect, it can be quite useful in a subset of patients. When you look at the waterfall plot, you can see that there's shrinkage all through here on the right-hand side for many of the patients, and in particular, those who were pre-treated as well too with other types of drugs. So we know that this drug can work after crizotinib and after entrectinib. There's evidence of that as well. Where we're running into problems with this drug is, that lightheadedness or dizziness, the dysgeusia, the taste issues, the numbness of the fingers, right, and the muscle weakness is quite debilitating in some patients in here. So I've generally not been able to find that I can get my patients on the full dose of repotrectinib in this case. It will move, however, into phase 3 with the repotrectinib versus crizotinib forthcoming for ROS1. by Bristol Myers Squibb. It'll be interesting to see, are we going to be able to even accrue, because many of us are trying to switch over to entrectinib, even with its side effects. We'll have to see. And Princess Margaret, we're opting to open this trial for now, knowing that we might abandon it over time if the standards change enough. Taletrectinib, this is the phase 1 data. Phase 2, we have 4 patients on right now, and a 5th to come. And you can see the waterfall plot is that it does work. It does shrink tumors in the majority of patients. The spider plot show that in many cases they're very durable over many months, if not years. In this case, some patients it fails, like it grows, and many of them it shrinks down to nothing for very long periods of time. And then it does seem to matter in the sense that if you use it as a first-line treatment, you get the best results. If you use that for second, a little bit less. And if you use it for third, worse. But even then, these are measured in months. So even those you get up to 8 months with multiple prior treatments for this. And when you compare with other drugs, in the preclinical world, taletrectinib does seem to do a little bit better in terms of its outcome. It has better selectivity for ROS1. Remember, selectivity for TRK gives you all those weird side effects with the mouth, with that weird taste in the mouth and the muscle weakness. Sometimes some patients can't even lift their heads up. So taletrectinib has way fewer of those side effects in this case. And this is the phase 2 trial that we have open right now. You don't need to know too much of the details, except that it's the usual standard one. There's one cohort for people who've never had any systemic treatment, one cohort who has had one ROS1 TKI, one with 2 ROS1 TKIs, one for everybody else as a basket cohort in this case. And like I said before, the standard is 306 for taletrectinib. In this case, is also 600 milligrams each day, similar to entrectinib. And it's given in 200 milligram tablets in this case. So this is the taletrectinib, which is the second of the 3 drugs. Repotrectinib is the first one. This is the second one, taletrectinib. And the third one doesn't have a name yet, Nuvalent 520 in phase 1. This is also very exciting because it has absolutely no TRK-B side effects. So it won't work on NTRK patients, which is fine, got lots of drugs for that. It will actually not have the same issues with the dysgeusia, with the muscle weakness. And with that, what we call withdrawal pain syndrome. Many of the NTRK patients that I've treated, or a few of them at least, end up when you stop the drug, you can't stop it immediately. You have to go slow and taper it down, or else the moment you withdraw it, they're in horrible pain, and you can give high-dose steroids and high-dose morphine and hydromorphone, and it won't go away until you restart the drug, and then you taper it off slowly. That doesn't happen with Nuvalent 520. So we're really excited about this. We're about to put our first patient on it. It's in phase 1. But even now, it is very selective for ROS1 over NTRK, like I said. Very good in vitro data, particularly for the resistant mutations that they have. And right now, if I just skip over here, those doses of 100, 125, and 150 that are being tested for the phase 1, they are well above the threshold for what should work for those patients with not only the ROS1 fusion, but with a lot of secondary ROS1 mutations as well. One of the common resistance mechanisms involved. It really gets into the brain. This is another one where you can see the before treatment, where you see all the all of the purple color in the mice, which is really where the tumors are, and then afterwards, after treatment, I mean, they all go away in here. So again, another very good drug that we're very excited about. I'm going to stop there because I now talked about ALK and ROS1, and I would like to move on to talk about EGFR exon 20. So there are a few characteristics of exon 20 that one should be aware of. One is that it's an insertion mutation that matters. It's not a substitution. If there is, sometimes there's a deletion on top of an insertion, but there has to be something inserted into there. It's generally somewhere around amino acids 767 to 773. and there's certain characteristics. In one end, they're the helical mutations, which are very rare, the near loop mutations, which are the most common ones, and then the far loop mutations, which are fairly rare as well. This is important because a number of the new drugs, like BLU-451 and semvasertinib, work better seemingly in the near loop mutations than in the far loop. For BLU-451, it's theoretical. For semvasertinib, I'll show you some data showing that it really is the case. And then and if you look at the drugs that have been utilized before we had all of these new drugs, we used to use afatinib. It still does work. I've had a number of patients where you get a decent response for 6 or 7 months, but it's not used as much now. Poziotinib had been studied a lot. It was partly based on the fact that it's partly a Canadian drug, but unfortunately, it was deemed too toxic by the FDA, so it's really not in development any further. Mobocertinib and amivantamab are the next two, and both of these have gotten a lot of press and excitement. So amivantamab is already available in Canada. Second-line compassionate access by Johnson & Johnson or Janssen, and they're going to close the enrollment for the compassionate access towards, I think, the end of the summer, when they anticipate that hopefully there will be funding for amivantamab at that point. And then there's mobocertinib. So mobocertinib is available through Health Canada and company-derived compassion program. It's still open to actually obtain it. So the data for the both is actually quite reasonable. I'll tell you what the big problem is. There's no head-to-head comparison, and we don't know how to sequence it. So we don't know whether it's better to do AMI followed by Mobo or Mobo versus by AMI, and there's not going to be any trial to help us do that. So it's a bit of a mess right now. What we usually do is we usually actually give amivantamab first and then apply for the Mobo. There's a reason for this. The amivantamab is resource intensive. It's given weekly in the first 4 weeks, and then every 2 weeks thereafter, IV. 50% of the patients will have a drug reaction on day 1. So the first day's dose is actually split between day 1 and day 2 of the first week for that reason. But once they have that reaction, or if they don't have that reaction, they usually don't have the reaction again. We don't quite understand why. So it tends to occur with the first dose. Having said that, it has way fewer issues with bad rash and way fewer issues with diarrhea. Contrast that with mobocertinib. Usually mobocertinib equals Imodium. And there are a number of studies, small studies right now, and empirical data being collected to actually see if maybe we should just start them on Imodium when we start them on mobocertinib. Mobocertinib is 160 milligrams per day dose. Is also difficult. Many of the patients can only tolerate 80 or 120. And it seems like the more you push the dose, like many of these EGFR drugs, the more you push the dose, like we did with afatinib, the better the outcome. And when you dial back a bit, it may not be quite as effective. So that's what's happening right now. The exciting part is a drug called sunvosertinib and BLU-451. BLU-451, my colleague Natasha Lale has it open, but it's a phase 1 dose finding study. So they open a few slots, then they close. And recently they've been closed for a while until a whole bunch of amendments. We're about to open sunvosertinib from Daiichi Pharmaceuticals, and that's an exciting drug, especially since there was data that was presented at this ASCO annual meeting. So there's a bunch of Wukong studies. Apparently there's up to Wukong 24. They're not 24 studies, but or not 24, not 24, I'm so sorry, but some other number that's in the high numbers already. And I asked the company, like, do you really have that many trials? And said no. And then I asked them, well then why don't you just consecutively name them? And they said, this is a Chinese company based in China, and only certain numbers are actually considered good numbers, right? Lucky numbers. So anything with a 3 and a 6 and an 8 are considered really good. And you never try to have any of these that have a 4 in them. So as a result, there's only a small number of studies, but their numbering is getting really high already because of these interesting rules. So this initial study design was basically on locally advanced and metastatic patients who received a bunch of systemic therapies before and have to have progressed on platinum-based chemo. And when given at 300 milligrams, you can see it looks very favorable. In the waterfall plot, lots of patients have shrinkage, which is showing that blue pointing down. And then if you can see at the top, many of them are yeses for having brain metastasis. That's what BM stands for. And also a few of them who also responded or had disease shrink had received amivantamab as well. What they didn't tell you, but I found out when I talked to them, was they had a few patients on mobocertinib, and this drug did not seem to work after that. So it's something to keep in mind, that this might be a replacement for mobocertinib or an alternative to it, but not necessarily one that you can use after mobocertinib in this sense. And then when we looked at exon 20, remember I said that there are the near loop and the far loop. Most of the patients that we have in exon 20 are in the near loop. This seems to have a benefit, whether it's in the two patients who are in the helical that responded in the gray, the green, that was primarily that of the near loop, and the far loop as well. This is a drug that seems to work for any type of subtype of exon 20 mutation. Subgroup analysis also showed that it seemed to work right across the actual board. And the duration of treatment, as you can see, most of these patients are still on it. You can see because they have the little black arrow pointing to the right for the swimmer's plots. And vast majority of patients did have a partial response, and most of these patients are still on it right now. Safety profile. So when I spoke with the company, because we're just starting to use semfrosertinib, and the majority of the patients are Chinese patients, that's an issue, because whenever you have a homogeneous single population to deal with, there may be certain characteristics, or you run it in one country. There's certain maybe conventions in the country of how things are reported that might over or underestimate certain things. So we're waiting for the North American version of this trial to come through, and Princess Margaret is part of that. That's one of my studies, and in this case, the diarrhea, it says all grade, but only 7.7% are grade 3. But we all know that basically grade 3 means you can never leave the bathroom. That's how bad it is, right? So if you have 5 or 6, bad diarrhea episodes a day, that's still grade 1. So we were trying to get them to tease out how bad is bad. And the company is not giving us that information. So we're interested to see what happens when we start using it right now. Otherwise, it's a very promising drug, as you can see with the other data that's there. It works clearly better. This slide is only there to let you know, to remind me to say that it works better if in patients who've never been treated before, but it can work also in patients who've been treated. But obviously the response rates and in each of the waterfall and the swimmer's plots are not quite as good on the left than on the right. So then Wukong 28, there we go, 28, because these are lucky numbers. This is a new study. This is the phase 3 trial comparing their drug with platinum-based doublet chemo. And for me, the important thing is they included a crossover. So if you got the chemo first and it didn't work, you can still get the drug. So we're excited about this. This will be hopefully opening soon in the late summer, early fall. In the meantime, we have the other study for semfrosertinib opening very soon as well too here. So we can accommodate patients who are exon 20 for trials in this case. I'm going to talk quickly about, I'm halfway through, KRAS G12C. So it's an oncogenic driver. You see it in a good 25 to 30% of lung cancer patients, or about a quarter of them, and are KRAS, and then slightly under half of them are thought to be G12C, so quite a number, about 14%. And so there's one drug that is currently available called sotorasib. It is not funded, and Amgen has an issue where they are afraid that if they supply the drug, then CADITH or the Canadian agency that assesses for cost effectiveness will go really slow because they're giving the drug out for free. So why should we, why should we do this faster? So they haven't been providing the drug. For anyone who wants to know, if you keep on applying, eventually you'll be able to get the drug for your patient, unless they die or something else happens to them. But because the reason why is that the MSLs were able to actually get, and the commercial teams were able to get a certain number of slots. So basically, when one patient falls off, then they can replace it with another. So normally, if you apply, they say, no, just keep on applying. But we're hopeful that you'll consider sending it down to us. So we have Adrian Satcher, one of my colleagues, is kind of our KRAS G12C guru. And so the mechanism of action of these inhibitors is that many of them have a covalent binding. There are different mechanisms, but the most common one is a covalent binding of an otherwise fairly smooth wall of the protein. And there's a little niche in there where this drug can fit in and permanently change the configuration of the protein so that the ATP cannot get in, and so forth. So when we look at actually the different combinations used in non-small cell lung cancer and the response data, it varies anywhere between about 20-something% to about 40 to 50% in this case. But many of these combinations are still in very early development. And I just want to mention that in the gigantic scheme of KRAS, which may include eventually KRAS G12D and other subtypes, the majority are G12C, and that the ones in red circles, or rounded squares, I guess, are all trials of drugs that are open at our center. Many of these are in phase 1. So Dr. Satcher, Adrian, tends to open a series of them because you only get maybe one slot a month to put a patient in, or one slot every 2 months to put a patient in. So we open several of them because then it's more likely that we'll be able to get patients in at any one time. So send them our way, especially now that sotorasib isn't funded, and many patients are not able to actually get those drugs. And to be fair, when CodeBreak 200, which was the seminal trial for docetaxel versus sotorasib in the second line, it was kind of nicknamed a drug that was so-so, not sotorasib, but so-so-rasib, because it wasn't as good of a benefit. Like the results weren't as good as we expected. And many of these new drugs we think that are nipping at the heels of sotorasib are probably more potent and more effective. So with that in mind, I'm going to finish off this section by really just talking about something totally different, which is small cell management. So up until recently, we've been using basically the same set of chemotherapy for the longest time, periodically replacing it with slightly new drugs and new addition of second-line drugs and so forth. The most recent developments seem to be one of two things. One is the addition of immunotherapy. And finally, more recently, lurbinectedin, which has been touted as kind of a new agent, one of the new agents to work. In the meantime, there have been so many targets for small cell lung cancer over the last couple of decades, and many of these drugs have unfortunately failed along the way. Lurbinectedin, if you were to kind of look up how does it work? Well, it's a derivative of a natural substance. And it seems to bind to the DNA minor groove, causing DNA strand breaks, which is this top blue part here on the right-hand side. But it can also influence a whole bunch of other activities, including inflammatory markers, angiogenesis, immunosuppression, induction of apoptosis, a whole series of things that can cause. This is a way to say either the drug kind of works in many mechanisms, and we're not sure which is the main one, if there is a main one, or that we don't have that much of a clue. So lurbinectedin is also known as an anti-transcription drug, which is kind of like saying it's a drug that kind of works to decrease the gene expression of a whole pile of genes. In other words, we're not 100% sure. What we do know is that it can cause DNA strand breaks in this case. In the seminal, what the company Jazz calls the seminal phase 2 single arm trial, patients were able to go through many months, in some cases, of treatments. Some of them many of them were in patients who actually had a long chemotherapy-free period before they needed to go on. And some in the blue had very short, less than 90 days in here. It was on this basis that they received approval, but you can imagine this isn't going to convince anyone to actually fund this. So this drug wasn't funded. It is, and part of the reason why is that there was a trial in which they combined a lower dose of lurbinectedin with doxorubicin or adriamycin and compared it with standard, which is topotecan or CAV chemo. And basically, there was no difference in the overall survival at all between the two. What was different was the fact that the single agent, the lurbinectedin with the doxorubicin had a lot less anemia, neutropenia, febrile neutropenia, and thrombocytopenia. So if you were to, and this is kind of what the company wants us to do, but many of us have done it anyway. If we want to extrapolate and say that, look, if we take off doxorubicin, which is really, really hard on the bone marrow, and we increase the dose of lurbinectedin, we probably would still have way fewer side effects than the old standard of topotecan or CAV. So if given the option of lurbinectedin, and it's a single drug once every 3 weeks, not topotecan's 5 days in a row every few weeks, or CAV's 3 drugs, it's easier to give, and so it might be just easier to use. So if I get it for free, I'll use it. If patients have to pay for it, it's probably not worth it. And you can imagine that right now, Cadith did turn down and say that it wasn't cost effective right now. The company is still offering this drug through certain centers. We're one of those centers because they want to collect real world observational data. If you have anyone who's failed small cell first-line treatment that you think you might be interested in sending down for lurbinectedin, send it down our way. We've already had one patient with Sunbrook come down already. The one thing you have to keep in mind if you're starting people on lurbinectedin is that extravasation can cause massive injury. So in other words, this is one of the drugs that if it leaks out of the IV, it can cause damage. One of my patients actually had a big, gigantic hole right here in the hand and ended up having to stop all the lurbinectedin for like 3.5 months, get plastic to debride this area, to scrape it all off, and then to let it heal him. For whatever reason, he's on cycle 10 and he's still responding to the treatment. So we're thrilled that's a case, but this was a disaster for him for a few months. Something to keep in mind, we put portacats in every single one of our patients now. We don't want that to happen again. So Princess Margaret has access to lurbinectedin by itself until the end of 2023, but we're opening the Lagoon trial very soon. And the Lagoon trial is a trial where they're comparing lurbinectedin alone with lurbinectedin with irinotecan, or dealer's choice of either topotecan or irinotecan. The only thing I can tell you is we're opening this trial to get access to at least irinotecan, because we hate topotecan, and irinotecan isn't covered in Ontario by CCO, but also gives an opportunity for people to try the lurbinectedin still moving forward. I would never design a study like this, and I won't go through the reasons why this is a mess of a study. We're opening really for access to our patients. Many of us have no clue how they're going to interpret a study like this moving forward. But anyway, there's a whole bunch of other trials. Many of them involve liquid profiling, tissue profiling. We try to do liquid profiling in every single one of our patients, as well as standard tissue profiling as well. And we have a number of ctDNA studies where we're tracking patients with early stage non-small cell lung cancer to see if we can identify patients early and then intervene early as well. And this is just, we can see for the targetable drugs. This is this month's open trials at our center. I haven't talked about CMET, NRG, or BRAF. We still have those trials that are available if people are interested in. So with that in mind, I've got a few minutes to talk about how do we find new targets, right? Because we've got all of these. Where do we go next? Improve selectivity is one way to do this. So I'm going to describe to you a CIHR-funded grant of mine that I share with Dr. Ming Chow, a pathologist here at Princess Margaret. The optimal study stands for organoids to guide post-resistance therapy in driver-mutated lung cancers. Mouthful, right? So basically, when patients receive a targeted agent, and when they finally fail it, we biopsy them. We take the tumor, we stick it in immunocompromised mice so they'll grow, and we also grow them as organoids, three-dimensional, somewhat spherical-looking blobs of tumor that we think better represent what happens in real life than kind of the two-dimensional cell lines that are grown. If we can grow them in the mice, we still try to convert them into these three-dimensional spheroids because they're really easy to test. The mice take months to test and are more expensive. You basically have to house these mice in like little mouse hotels, right? And you got to feed them as well, right? You don't have to do quite as much for these other blobs of tissue, and those you can test within weeks rather than months. And then basically we run experiments. I tell people that one of the things I do is that I run clinical trials on mice and organoids in this case. And we try to figure out, we try different drugs and we see which drugs might work. And so that will help us understand that maybe in certain types of tumors, certain drugs will work. And then we do a lot of profiling to actually try to understand what is it in this particular model, in this particular patient's sample, certain drugs worked and certain drugs didn't, so that we can then maybe use those as biomarkers for the next patient moving forward. So that's our goal in terms of doing this. So what we need is to actually have people send us. So we have our own patients who are on targeted therapy who fail, and we try to biopsy those, and we try to grow these out. If you have patients, or if any centers have patients that are aggressive and fit and want to try some trials, send them to us. We might biopsy them, try to grow them out, and use this technique to try to figure out how best to treat our patients, along with trying to put them on our standard clinical trials as well. So this is just an example of what organoids look like. You can see kind of clusters of cells that are growing in the media rather than kind of a flat surface of cells. And then we would then create heat maps, where in this case, the blacker or the darker the color, the more responsive those cells are. So those cells tend to shrink a lot more when they're exposed to certain cells. So you can see that there's an agent called as a Lilly drug, LLY283. And that drug, there's a lot of response to. It seems to work quite well in a number of these organoid models. And so we found that this was a PRMT5 inhibitor, the Lilly 283 compound. And so it's allowing us to then study this concept. At the same time, our colleague, Adrian Satcher, was opening a trial of a drug that inhibits PRMT5, but only in patients who have an MTAP deletion. So we're screening all of our models for this loss, and then using these new models to test this new drug. So we think it's really neat that we're now going from bench to bedside and from bedside back to bench again in this case. And this is the trial that just opened. So we will have to we're screening all of a whole pile of patients to see if they have MTAP deletion, and in which case they would qualify for this phase 1 study. Okay, and so this might be one way to reverse resistance mechanisms in this case. Another way is to combine in order to have target resistance, right? They're using combinations of drugs. So when we were looking at using our organoid models, we found something interesting because we had a number of models where we biopsy after failure of osimertinib in our EGFR positive patients. And there's a drug called AZD2811, which are trying to resurrect because somehow AstraZeneca decided to kibosh and stop developing this drug. But we're looking at other aurora kinase B inhibitors as well. That this drug and maybe this pathway or this target can reverse osimertinib. We see this because if you look at each one of these graphs, anything that is closer to the left or drops down faster means that it is sensitive, and all the graphs in red are the ones that are the combination of osimertinib with this new aurora kinase B inhibitor, and you can see the aurora kinase B inhibitors in black, the osimertinib alone is in black, but when you use those two drugs together, you get that shift, you get that red line, which suggests that you're now making the cancer sensitive to the combination treatment. that wasn't sensitive to either of those drugs alone. So we're excited about this, and we're now testing other aurora kinase B inhibitors. So this is the bench, hopefully back to bedside. We hope to then eventually take this back and maybe try it in phase 1 studies if we can confirm this. SHP2 inhibitors are also very exciting right now because they work downstream of many pathways. And in particular, kind of the RAS pathway, the RAS, RAF, ERK, the PI3K, AKT, and also the JAK-STAT pathways as well. So it's kind of something that you might not use by itself, but you might use in combination with one of these other pathway blockers as well. There are many different types of SHP2 inhibitors. I won't go through them. There have been combinations that have been used in a number of settings for ALK and BRAF, and also with IO, and with theoretical reasons. And so there's now a whole bunch of SHP2 inhibitors that are being used, the KRAS G12C, and we have a couple of them open. One that's open is GDC 1971, and another one they're opening soon that involves TNO 155 as well. So again, we're really excited about these new ways of dealing with KRAS through combinations as well. And finally, novel delivery systems. So we all know about these concepts about antibody dependent conjugates, right? So in this case, we have a drug called trastuzumab deruxtecan available already for breast cancer, but now being used for ERBB2 exon 20 mutations in non-small cell lung cancer. And then these are all the DESTINY trials. So these are basically monoclonal antibodies that are conjugated, that have a linker attached to them, and then have a bit of a payload, a kind of a chemo bomb. So you have something that you have the part that's targets, right? The targeting portion of the missile, and then you have the bomb portion of the missile as well, which is really the deruxtecan portion of it. And then so what happens is that these monoclonal antibodies get actually pulled inside the cancer cell because they are hitting it's a targeted agent. It brings it in, and then the bomb gets released to kill off the cells. Very neat in principle, and we're getting some good successes in some cases. So our original study, which DESTINY Lung 1, which we participated in, did seem to have a benefit. In a subset of patients, you can see lots of shrinkage. Biggest problem with this drug is actually that of interstitial pneumonitis. And you have to be pretty careful with use of this drug. So we then also had DESTINY Lung 2, which I was involved in. Same thing, the waterfall plots, you can show lots of benefit in this case. And I'm going to skip through this to basically say that there were more toxicities, particularly in relation to interstitial lung disease. So DESTINY Lung 4 is a study that my colleague Penny Bradbury has opened, and it's going to close soon. And it's only for first line, initially diagnosed ERBB2 exon 20 mutated patients, or mutated tumors in patients. And we would love the possibility of putting in one or two more in before it finally closes in. So if you see any of those patients, consider sending them our way as well. These are good drugs. We've had so far 5 patients on, and all 5 patients have had at least a partial response. Unfortunately, one patient ended up with interstitial lung disease, right? So it's just something to keep in mind as well. And then finally, there are these new targets, in this case, anti-TROP2, which we're very excited. We were involved with the initial TROP2 studies, and we'll be opening new ones coming through as well, too. So this is another antibody, a drug conjugate, right, where you have a humanized monoclonal antibody. You have the linker, right, that attaches it all the way through to this hidden bomb that will go off once it's cleaved from the linker itself. So we're actually in the middle of getting Dato-DXd to apply to our mice right now. So we're very excited to actually see how this type of drug would work in our mouse clinical trials in this setting. So at the end of the day, the different things that I've talked about include, this problem of resistance in oncology, right? Where we're also finding new drugs to target this concept of matching the right biomarker with the drugs that are already available, which is what our optimal study in organoids and mice are doing. And then this combination, combining drugs to overcome this resistance becomes another mechanism. And then these antibody drug conjugates, as novel delivery mechanisms are also quite exciting as well. So if we put it all together, what do we get? We basically get Prosecco delivery. So in this case, in the future, maybe one or more of these mechanisms, the pro, the say, the co, or the delivery, or combinations of them, will allow us to move the field forward. And I think we're all very excited right now to see at all these possibilities. And with that, I'll stop and take any questions. Maybe I'll stop sharing so I can see.
Thanks so much, Jeff. That was really interesting. You guys are doing some amazing work there, and helpful for us to know so that we can continue to refer to you.
And remember, we send them back and we share them back with you.
Yes, you've always been, and you're great at helping us. Helping us all the time just to identify what we can do, because sometimes it's not clear. Question for you, which I don't think we touched on yet. In terms of these mutations,